Hello, this is Dr. Robert Auger from the Mayo Clinic. Welcome to this educational activity on recognition and pharmacologic management of idiopathic hypersomnia, featuring meeting highlights presented at Sleep 2021, a joint meeting of the American Academy of Sleep Medicine and the Sleep Research Society. I want to first start by technically defining idiopathic hypersomnia as per the International Classification of Sleep Disorders, or ICSD criteria, version 3. The first criterion stipulates daily periods of irrepressible sleepiness present for at least 3 months. The second stipulates an absence of cataplexy so as to distinguish the sleepiness associated with this condition from narcolepsy type 1. The third mandates that fewer than 2 sleep onset rapid eye movement periods on multiple sleep latency test, or MSLT, or fewer than 1 if a sleep onset REM period is observed on the preceding overnight sleep study. And that is predominantly to differentiate this condition from narcolepsy type 2. And then the presence of one or more of the following: a mean sleep latency of 8 minutes or less on the multiple sleep latency test. As discussed in another slide, this can be a difficult criterion to meet. And therefore, the newest edition has that the alternate criterion of total 24-hour sleep time of at least 11 hours on 24-hour overnight sleep study or wrist actigraphy in association with a sleep log, the latter averaged over at least 7 days. And that has its own challenges in meeting that criterion as well. Insufficient sleep, that is chronic partial sleep deprivation, needs to be ruled out, as that's the most common presenting the most common cause of sleepiness in clinic settings. And then hypersomnolence and/or MSLT findings are not better explained by other causes, for example, medications and head trauma. The additional supportive features, at least in my view, are as important and if not more important than the the primary diagnostic criteria, and that is severe and prolonged sleep inertia. Sometimes the sleep inertia that these patients experience is described as sleep drunkenness, so as to differentiate it from the kind of standard or routine sleep inertia that most or all of us experience initially upon awakening. In at least 30% of patients, very prolonged, unrefreshing sleep is described, hence that alternate diagnostic criterion. If the MSLT MSLT criteria are not met, and that is so a lot of these patients will sleep 10 hours or longer for the nocturnal sleep period, and then sleep even longer during the day and remain unrefreshed. Finally, on the overnight sleep study, this is quite unusual for adults spending the night in the sleep lab, but you may observe very high sleep efficiency, oftentimes 90% or higher. I mentioned that the criteria that insurance providers pay most attention to in the ICSD criteria are objective parameters, measurables. And these include the aforementioned values on the MSLT, multiple sleep latency test. The problem with that is that if we look at some of the supportive features that I just reviewed of idiopathic hypersomnia, and if a group of experts is otherwise very convinced that the patient has idiopathic hypersomnia and other conditions are ruled out, there's a substantial proportion of patients who will not meet that MSLT criterion. That is why in the newest ICSD they include this assessment of nocturnal sleep duration criterion. That can also be challenging to meet because, at least in the US healthcare system, it's going to be hard to proceed with a 24-hour overnight sleep study. The 7 days of actigraphy is much more doable, although again there are difficulties with reimbursement for actigraphy as well. One way to try to get around that is to just extend the opportunity for sleep during an overnight sleep study so that you allow at least 11 hours in an attempt to meet that criterion, just in case you don't meet it with MSLT criterion. So the other challenge with this condition, there is an absence of biomarkers and pathognomonic clinical features. Specifically there, I'm referring to, for example, with narcolepsy, you have cataplexy, which is pathognomonic for narcolepsy type 1. Also in narcolepsy, you have hypocretin deficiency that can be measured in the CSF of patients, and there are no such findings in patients with idiopathic hypersomnia. Perhaps as you'd expect with a condition that starts with the word idiopathic, the prevalence of the condition is unknown. The best study that I could find per date up to today's date was a recent study that was published in the Journal of Clinical Sleep Medicine that reviewed claims analyses over recent years. And based upon those claims analyses, they estimate 10.3 per 100,000 persons. So we're talking about 0.01% of the population. Based on claims analyses and other studies, it appears to be less common than narcolepsy. A lot of this just depends. If you're someone like me, there's a lot of referral biases, and I would say that I see actually more patients with idiopathic hypersomnia than narcolepsy, perhaps because it's harder to recognize and harder to treat. And then finally, there are some data that suggest that incidence and prevalence may be higher in females than males. The onset is typically during adolescence, late teens, early 20s. Due to some of the challenges I mentioned previously, the diagnosis may be delayed significantly, so you could see someone who's further along into their adult years, but with history, you find that they've been sleepy for many years prior to the clinical encounter. It should be considered chronic in most patients when you're having the discussion about the diagnosis, although spontaneous remission is estimated to occur in about 20% of patients, often after many years of symptoms. Really no way to predict for whom that's most likely to happen. Again, consistent with the idiopathic part of the name, the pathophysiology remains unknown. I mentioned before that no deficiencies in wakefulness promoting neurotransmitters such as hypocretin have been observed. More recently, they've looked at patients with hypersomnolence and looked for deficiencies in histamine or the metabolite of histamine, and have found no deficiencies in those substances either. There's tentative support for the presence of an endogenous substance in the cerebrospinal fluid of a subset of IH patients that modulates GABA-mediated inhibitory effects on arousal. That is to say, there was a study by Rai and colleagues at Emory that took the CSF of IH patients, compared it to the CSF of controls, and found that GABA activity was enhanced in the CSF of IH patients. And that will actually pertain to a couple of the treatment recommendations that I mentioned down the line here, this possibility of this modulator of GABA activity. A subsequent, more recent study failed to replicate these findings, and if you're interested, there's a fairly contentious exchange, a relatively cordial scientific exchange between the two authors, but the findings were not replicated subsequently. Other potential explanations for patients' complaints of sleepiness: polysomnographic studies have shown decreased slow wave sleep. Slow wave is a very deep restorative level of sleep, and increased REM sleep compared with healthy controls. Contrary to popular opinion, REM sleep is actually a very light stage of sleep, so we're talking here about a decrease in deep levels of sleep and an increase in light stages of sleep compared with healthy controls. One of the reasons that sodium oxybate may work in this population, we'll discuss that later, may be that that sodium oxybate has an effective increasing percentage of slow wave sleep. And then, of course, given all this divergent information, it's very possible that there are multiple etiologies that are ultimately considered to be responsible for this condition. At the end of the day, regardless of what causes the condition, I always like to think of things from the patient point of view, quality of life. And I can tell you that patients that have this condition are very troubled. They're often in trouble academically or occupationally, struggling with their families, being accused of being lazy, etc. And this is a study that was published some time ago in the Journal of Clinical Sleep Medicine, a Japanese study. And they use the SF-36 quality of life assessment, and you can see the national norm in the dotted line here above. And if you look, you can see that compared with normative data, patients with idiopathic hypersomnia were the majority of these patients, but it also included other conditions such as narcolepsy, that they, with the exception of physical function and bodily pain, they score significantly worse than the general population in all of these other domains. And this is another, additional claims analysis data that discusses some of the comorbidities associated with idiopathic hypersomnia. And this may pertain to quality of life impairments that I'll show in a subsequent slide. But there's a high frequency of mood disorders, including depressive disorders, headache, migraine, and hyperlipidemia. So I first wanted to start the updated clinical practice guidelines for treatments of disorders of hypersomnolence were presented during the sleep meeting and should be published in short course. This really is intended to be, or should be, a living document updated continuously. There are several medications that did not make the timeline cut for this particular edition, but please keep in mind that it is a living document. The FAASM uses GRADE, that's an acronym, G-R-A-D-E, which not only takes into account the quality of evidence, but also a risk-benefit analysis for the patient from the standpoint of potential benefit, what alternative treatments are, adverse effects, cost to the patient, etc. With that in mind, you can see that we have a strong recommendation for modafinil, and that for the remaining treatments that will be discussed, we have conditional recommendations taking all the variables that I mentioned into account. The other thing that when you're using this GRADE assessment, you provide recommendations based on critical outcomes. And there also are important outcomes, and the task force in a consensus-based fashion differentiates between the two. For purposes of this presentation, and since it's the critical outcomes that guide the ultimate recommendations, I'm just going to review those critical, pertinent outcomes. But I urge you to read the guideline, because it also can provide some good background information on how we came to these recommendations. So critical recommendations: disease severity, no surprise there, excessive daytime sleepiness, quality of life, and work, school performance, attendance. And I think this captures the concerns of the IH population pretty well. I will say that very few studies examined quality of life, and I don't believe we identified any that spoke to the work, school performance, or attendance parameter. We only reviewed studies, or only included studies for which IH-specific data was published or could be obtained. And so some of these authors were very gracious in providing additional data that was not published so that it could fit into the GRADE assessment model. And just as a point, an example here, we excluded 2 modafinil randomized controlled trials for which IH and narcolepsy data were combined. So first, to give you an example, and I won't delve into the sausage making too much here, hopefully, but so modafinil, we mentioned this is a strong recommendation. At the time of the publication, this was actually based on 1 randomized controlled trial from Meyer 2015. Only 31 patients, but believe it or not, when you're looking at a condition like that, that's actually a pretty good number of patients. I would argue that they're actually taking a fairly low dosage of modafinil, 200 milligrams a day for 3 weeks. The clinical significance threshold was a change in the Epworth Sleepiness Scale score of 2 or more, and that was actually met, and then some. Epworth improved 4 points as compared to controls. When we look at these guidelines, these forest plots, the red lines will show the clinical significance threshold on either side of the null effect, which is 0. And so, for example, here with this green dot is the mean value, and you can see that it exceeds the Epworth value that's required for clinical significance. The randomized controlled trials start at a high level of certainty, and they get downgraded depending on various findings. This one was downgraded because the confidence interval of the effect crosses the clinical threshold parameter. So moderate certainty evidence that the modafinil improves the Epworth Sleepiness Scale score in patients using the medication at this dosage and for this period of time. So if you look at that same study and you look at MWT, Maintenance of Wakefulness Test, is the counterpart of the multiple sleep latency test. Instead of measuring how easy it is to fall asleep, it measures your ability to remain awake in a soporific setting. And this would be something we would do, for example, with an airline pilot, safety-sensitive industries where it was very important that the individuals are extremely alert, almost to a superhuman extent. So in this particular instance, the MWT results met clinical significance. We described that as at least a 2-minute improvement in the MWT. This one, on average, was actually 3 minutes higher. It was downgraded twice in this instance because not only does the confidence interval cross the clinical threshold for favorable effects, but it also crosses the threshold for unfavorable effects, meaning that individuals would be more sleepy on the left side of the red line. So low certainty evidence for the MWT. And then for the clinical global impression of severity, we again met clinical threshold significance, but we downgraded once for sample size and the fact that the confidence interval includes clinically insignificant effects. So I wanted to include a study that was sort of suffered from unfortunate timing, at least from the standpoint of publication of these guidelines. But my hope is that this clinical practice guideline will actually become kind of a living document. So if we include the newest INWAY study from 2021 and look at, again, the Epworth Sleepiness Scale score changes when using modafinil in this patient population. Once we get more numbers and we're able to perform a meta-analysis, so now we're up to about 50 patients, you can see that this diamond represents this black diamond represents the effect of the combined meta-analysis. And there we very firmly have modafinil in the favorable effect range, and we've shortened this confidence interval so that it's very firmly within the realm of positive clinical benefit. The same thing happens when we combine the INWAY study and look at the MWT, so this objective measure of the ability to stay awake. Now that we combine these studies and are able to do a meta-analysis, the favorable results are very firmly on the right side of that clinical significance parameter. There is a certain amount of patients, more so than in narcolepsy, of IH patients that are treatment resistant to what I would consider standard treatments, stimulant therapy. I think I would include sodium oxybate in standard therapy. And the Emory group has investigated alternate therapies for treatment-resistant patients. And they did one study with clarithromycin, and the rationale for this is that it serves as a negative allosteric modulator of GABA for GABA receptors, meaning that instead of potentiating the effects of the GABA receptors as the CSF of these select IH patients appeared to do, this actually seems to mitigate those effects. And so with that rationale in mind, Trotti and colleagues looked at 10 patients with idiopathic hypersomnia, provided 500 milligrams clarithromycin BID for 2 weeks, and saw an Epworth improvement of slightly over 3, which met clinical significance. And again, probably because of these small numbers, it was the certainty of evidence was downgraded for the sample size and the fact that the confidence interval included clinically insignificant effects. But definitely something that if you treat enough of these patients, you will have to reach for at some point. This was the only study that looked at quality of life parameters, and you can see that with the FAASQ, that's the functional outcomes of sleep questionnaire used very commonly in the sleep literature, as well as we see again this short form 36 health survey questionnaire. And for both of these parameters, clinical significance for improvement of quality of life is met, but downgraded for some of the same reasons mentioned above. And again, not surprising when you're looking at the low number of patients under investigation here. Methylphenidate for IH, the only, and again, full disclosure, I was part of this study, this Ali 2009 study. One of the issues with these medications, we're not saying that necessarily something like methylphenidate, for example, is of lesser value or may not be beneficial for a patient with IH. It's just that the available data is less robust, and part of that almost certainly has to do with the studies that are industry sponsored are going to have the ability to create higher quality studies. But this was an observational study. 61 patients prescribed methylphenidate at varying dosages, essentially as high as is necessary and tolerated. And you get some of the sense of treatment resistance here. 41% described a complete response, 21% partial response, and 3% poor response. You had a lot of patients that stopped methylphenidate for various reasons. But this is very, very low certainty evidence, something that, if even for cost purposes, will probably be reached for first, but realizing that there may be some resistance to benefit in this patient population. Pitolisant is one of the new kids on the block. This was just an observational study, so very low certainty evidence. If I remember correctly, they were looking at patients retrospectively, 65 treatment refractory patients who were then prescribed pitolisant, which is novel compared to the traditional stimulants as far as its mechanism of action. It is a histamine agonist. And the Epworth improved from pre-treatment baseline by almost 3 points. And then the next recommendation for sodium oxybate for idiopathic hypersomnia. This is very low certainty evidence because it was an observational study. There is some good data for use of sodium oxybate as a stimulant sparing agent for narcolepsy populations, and I've applied the same for IH. What I mean by stimulant sparing is you often have patients who you reach an impasse in your ability to prescribe a stimulant because of adverse effects, because of a plateauing of benefit, a variety of factors, and prescribing adjunctive sodium oxybate in those instances, patients can derive benefit. But this particular study, we have on-treatment information for 25 participants. As mentioned before, our clinical threshold for improvement was a change in Epworth by at least 2 points. And you can see that that clinical threshold on average was met for this patient population. Flumazinil is very interesting. Flumazinil is a benzodiazepine antagonist, and in the study that I mentioned before of the idiopathic hypersomnia patients that showed potentiation of GABA receptors in their CSF as compared to controls, this group logically used flumazinil, which is a benzodiazepine receptor antagonist, and benzodiazepine receptors are part of this GABA complex, and they did show symptomatic benefit from flumazinil in 63% of patients, with a sustained clinical benefit in 39% of patients. We ultimately decided not to recommend this intervention for a variety of reasons. The evidence was based on 153 consecutive patients reviewed retrospectively, and it wasn't that we thought that it wasn't necessarily effective. A lot of it is just practical issues. You need to go to a specific pharmacy at Emory to have the flumazinil compounded into either a transdermal or sublingual form. There are cost issues. I think virtually no insurance providers will cover that intervention. There's not a lot known about safety of these interventions over the long term. So it's very interesting and a very provocative study, but at this point in time, we are not providing a specific recommendation, but that doesn't mean that if you have a patient that's treatment refractory and desperate in other respects, that this shouldn't be sought. Okay, so that completes the review of the updated clinical practice guidelines. These next few slides will look at data presented in the meeting itself. And so obviously these guidelines did not make the cut this time, but certainly will the next time. These next few slides look at the efficacy and safety of lower sodium oxybate in a phase 3 controlled double-blind randomized withdrawal study in adults with idiopathic hypersomnia. Right away, as compared to the studies reviewed before, you see we have a relatively large number of patients, 154 with IH. In the past, and some providers still think there's an important distinction between idiopathic hypersomnia with and without long sleep time, and both of those patient populations were included in this study. Participants were either completely treatment naive, and so therefore at the end of this study they would have been exposed solely to low sodium oxybate. That was a relatively rare occurrence. Or they were taking medications previously, including sodium oxybate, alerting agents, or both. If they were receiving sodium oxybate at study entry, they had to show some kind of clinical improvement of EDS, with the assumption that clinical improvement would be sustained with the low sodium oxybate. And then participants not taking sodium oxybate had to show some evidence of treatment refractoriness, as defined as an Epworth Sleepiness Scale score of at least 11. Use of concomitant and alerging agents, which really is the norm rather than the exception, was allowed if there's a stable dose for at least 2 months, and if the ESS scores were at least 11 at screening and baseline, and then that dose and regimen had to remain the same throughout the study while the low sodium oxybate was introduced. So you can see that here we enter the, so when subjects are all of them are taking the low sodium oxybate, you see a very significant improvement in the Epworth Sleepiness Scale score. Once subjects are randomized to either placebo or low sodium oxybate or continuation of low sodium oxybate, you see a continuation of that benefit in the LXB group, and you see a pretty impressive worsening of the Epworth Sleepiness Scale score in the placebo group. It used to be in the past that the ICSD used to differentiate between IH with and without long sleep time. and at one point that was thought to be an important distinction because of differences in the phenotype of the patient. And just addressing that, or addressing those who still feel strongly about that distinction, the subgroup analysis found comparable treatment effects in patients both with and without long sleep time. So one of the things that I like about this study is that I mentioned that that sleepiness doesn't seem to completely capture this population, and a lot of IH involves profound sleep inertia, long, unrefreshing naps, cognitive complaints, and there is this scale called the IHSS, Idiopathic Hypersomnia Severity Scale, that has been validated. It seems to really capture a lot of the flavor of these patients, and the results were very similar when we look according to that scale. Again, we have benefit among all that are receiving LXB through the stable dose period, and then once the group that is randomized to placebo shows a worsening in their IHSS scores, then you see maintenance of improvement in the group that remains on LXB, and again, comparable effects in patients both with and without long sleep time. If you practice sleep medicine long enough, you will know that sleep inertia is one of the most problematic symptoms to treat. There are no standardized treatments out there. There are a lot of anecdotal treatment reports in literature, many of which are hard to enact. But this is a big deal because it really contributes significantly to occupational, academic impairment, may even prevent the patient from taking medications because they're not able to wake up in time to take the medications. So I was very interested in this particular abstract from the sleep meeting, which used a visual analog scale for sleep inertia, and again, really demonstrated favorable results as previously, that when the group that was randomized to placebo as compared to the group that remained on LXB, there was a significant difference in this sleep inertia parameter, much more favorable with the group that remained on the LXB. The other issue with sodium oxybate is dosed twice nightly, as is LXB at present, just because of the duration of action of the medication. But patients with IH may not readily awaken for a second dose, and I can certainly tell you that that's a common occurrence. So this group astutely looked at compared groups that were taking the medication either once a night or twice a night, and efficacy and safety was demonstrated for both dosing regimens with similar results. So I think that tells me that I don't have to fret as much as I might presently if they're not able to take it at that twice nightly recommendation. So in summary, IH is a rare central disorder of hypersomnolence. If you are a sleep medicine provider, you may not view it as particularly rare because of referral biases. The primary symptom, at least as defined by the ICSD of IH, is excessive daytime sleepiness. But I really think that the sleep inertia and prolonged unrefreshing sleep are equally, if not more important in certain patients, and hopefully future ICSD additions will address those complaints more definitively. IH symptoms significantly reduce health-related quality of life. So our goal, of course, is to improve that quality of life with treatment. The pathophysiology is unknown. Diagnosis is challenging because, as I mentioned before, these lack of biomarkers, the lack of pathognomonic clinical features, and some difficulties meeting currently established diagnostic criteria. There are presently no FDA-approved treatments, but lower sodium oxybate, I suspect, will be FDA-approved, which will be quite welcome by the end of this year. Other candidates include, as reviewed, with varying degrees of strength, are modafinil, sodium oxybate, pitolisant, methylphenidate, clarithromycin, and despite the fact that We provided no recommendation for the reasons I mentioned before. There at times is also a role for Flumazinil. This concludes our discussion for today. I hope you found the activity informative and useful to your practice and encourage you to participate in future modules. Thank you very much for participating.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.